going to go with moving ahead with hemophilia. This afternoon, we're going to be dealing with the more of the aging aspects of the lifespan, of which I'm a proud member. I don't exactly. I'm a somewhat unwilling member, but trying to embrace it. So we've been working hard on this aging program for the last couple of years, and recently we co-conspired with Pfizer and Yola Zdanowicz, who is the owner and president of Ensemble, a boutique health research and strategy firm. Over the past 30 years, Yola has partnered with health organizations to inform health policy programs and health education. She's the co-author of a host of medical journal articles pinpointing unmet health needs in Canada. Prior to Ensemble, she led the health practice at 2 research firms and worked at Sunnybrook's Odette Cancer Center and the Center for Addiction and Mental Health. Yola is passionate about the value of research. She feels this critical tool when developing health education and programs, given it helps to bring alive the knowledge, opinions, and the needs of a community. She's thrilled to be here today. She's becoming a good friend. We've worked very hard together over the last little while, along with Pfizer, to get this research off the ground. It's very exciting, gives us some insight into aging with a bleeding disorder. And here she is to present the results from that moving ahead with hemophilia. Thank you.
One of the most rewarding things about being a health researcher is when you can give voice to a community. And that's exactly what we're going to be doing here today. I'm going to be doing that, and Rick is going to be helping with that process. This project goal was really ultimately about informing the development of resources for Canadians aging with hemophilia. I and Ensemble were commissioned by Pfizer to do the project in collaboration with the CHS and with the Steering Committee of Healthcare Professionals. The approach was using in-depth interviews. It was a qualitative approach. It was meant to really get down deep into the experiences of people with hemophilia, aging with hemophilia. It was about listening to their experiences, their opinions, their feelings. It was not about a counting exercise. It was about talking to a small group and getting right down deep into their experiences. It was about sparking ideas. We spoke to 17 men, 40 and above, and we recruited them with the help of the CHS, with healthcare practitioners, and also with a panel company that had people with rare diseases in their panel. Our goal was to speak to a cross-section of individuals with different experiences, and we did just that. We recruited people both with severe, with moderate, and with mild hemophilia, and hemophilia A and B. People had different experiences with other health conditions. 13 people had been diagnosed with hepatitis C, 5 with HIV, and people were taking factor in different ways, half on demand and half prophylactically. There was a wide cross-section of age groups amongst the men we spoke to, and they came from a variety of places in Canada. 15 of 17 were members of the CHS. Here are their stories.
I mean, it used to be you could walk into a room, a meeting, a gathering of us, and you could pick out every hemophiliac in the room by the walk. Now, they can hide amongst you.
There was a real acknowledgement that the landscape of hemophilia has changed tremendously with the advent of new treatments, both in terms of convenience and in terms of not having as many bleeds because of prophylactic treatment. There was also far less risk of blood infection, and there were advances both in hepatitis C and in HIV treatments. the ideal when it came to the men we spoke to was having an oral therapy or gene therapy.
I am 45 years old. I wish. I think like a 35-year-old, and I feel like I'm in a 90-year-old body. It's difficult to get tasks done.
The long-term impact of bleeds among this group of men was profound. We heard stories about difficulty walking, arthritis, reduced mobility, and people spoke about multiple joint replacements. The long-term impacts also resulted in strokes, in brain hemorrhage, in paralysis, in blindness. These were the stories people were sharing with us. And it made those simple tasks of somewhat simple tasks of opening up packaging or infusing quite difficult for the people that we talked to. Some individuals said that they were deemed too young for joint replacement in this age group as well.
Now, I have arthritis so badly that even though I'm treated prophylactically and have never let a bleed go untreated, I'm still at the point where I am on opioid medication just to get by on a day-to-day basis with the amount of pain that I'm feeling.
Pain was a reality for so many of the people that we spoke with. And there was lack of clarity about what pain medication some people would take because of the fact that some of them would cause some thinness in terms of the blood coagulation. So it was hard for them to know exactly what to take in situations. Some spoke about long-term opioid use and addiction. People wanted other alternatives, but there wasn't very much clarity about where to get those, whether or not the medical community was in favor of some of those, and whether practitioners that they would go to would have some kind of background in hemophilia.
If I go to a grocery store or to a shopping mall, I may get 100 feet or I may get 1,000 yards. And then all of a sudden, my ankle will lock in place and I have to walk with my ankle at 93 degrees in excruciating pain all the way back to the vehicle. So you don't want to be parked at the far end of the parking lot. And it amazes me how many people, when they see me getting out of the vehicle, take the time to tell me how irresponsible I am to be using the handicap space.
The world becomes smaller. People have reduced mobility, they're less involved in social and family activities, and people are leaving work early because they can't keep up with the rigors of the job. They're also much more careful about what they do. Their finances are restricted, and family members are helping with things like driving. There's also weight gain, which in turn causes some low self-esteem and some pressure on the joints.
I don't dwell on it. I don't feel like a victim. I never dwell on the frustrations part of it. You just do it. You really have no choice. I don't sit and feel sorry for myself. I just power through it. This Stoicism was apparent among most of the people that we talked to. The sense of the glass is half full. The sense that other people are much worse off than me. And in fact, as researchers, when we were talking to people, when we framed our questions as what challenges are you facing, what needs do you have, people said, I don't have challenges. I don't need anything. We had to start listening to people's stories to get a sense of what they were experiencing, because when we framed questions in that manner, which we didn't after we started, we learned that this was the attitude and the way that people sort of felt about their lives. So not to dwell. People didn't want to be fussed over, and they say things like, I'm just getting old before my time. Other people are worse off. The ability to be who you are and not have people judge you or place their own rules on you. So you tend to keep everything to yourself. Aside from those professionals you deal with regularly or pseudo-regularly, it's really just family.
Privacy was extremely important. In fact, some friends knew, family knew because you've grown up with those individuals, but employers, a lot of them did not know at all. the general public, there was a feeling that they didn't understand the men that we spoke to. And also that fear of discrimination in the workplace, the fear of getting hired in the first place if they disclose, or not getting a promotion if they started talking about their condition. In addition, it was also about if they accessed the health services at their employers, they would be found out. So people were quite private, even to the extent of not wearing a medical or alert bracelet because they didn't want to telegraph their status. Also, it had implications for even talking to some healthcare practitioners like social workers because they didn't feel that kind of formal support was necessary. I don't need that type of support, they would say.
There are a lot of people who don't want to get involved in a relationship with someone with HIV. There's still an awful lot of stigma around HIV and an awful long way to go, which is different from where we were 20 years ago, but it's still not in a comfortable place.
Well, hemophilia took a lot of the day-to-day kind of physical impact. It was HIV and hepatitis C that really impacted people emotionally. Obviously with the impact on relationships, but also that connection to the blood-tainted scandal, the whole issue about also why me? Why am I a survivor when so many of my peers are now gone? It was isolating. People suffered from depression and they were quite lonely. When it came to hepatitis C, it had been a long sort of undulating road because people had been promised a treatment over and over again that was effective and they had been let down. It had happened over and over again, and now they admitted that there was a cure, but they were a little skeptical and they felt that there was still some enduring impact, whether that be liver cirrhosis or extreme fatigue.
Growing up as a kid, you always think that you're the only one out there with hemophilia, but when you join a chapter and become part of it, you realize that everybody's in the same boat.
The CHS was a huge sense of support for the men that we spoke to, in part because this was a community where you could share your experiences with people that understood. You could come together. In-person events were really important to people. You can be yourself, and also you could give back through involvement in local chapters. One of the critical parts of the support was the provision of information from the CHS, so people felt that they knew about new treatments, knew about the condition. In addition, one of the key sources of support, as we've heard today, were the hemophilia clinics. Even though people went once or twice a year, they felt that they had support 24/7. The nurses were there to call them or for them to call. They got great information about new treatments. I've never seen a community more informed about new treatments. And also the clinic people themselves offered a great lifeline because they were disease consultants to other healthcare practitioners treating individuals with hemophilia. They kept them safe. They ran educational seminars for people outside of the community, which was so huge. People felt that they got exceptional service from the clinics. The cases where there were some challenges were where they felt that they had to travel very far to clinics, where the referral process wasn't as smooth because there were long wait times to see somebody, or when they finally got to see that person, they didn't know as much about hemophilia, or where there was rigid rules.
I identified myself to the ER nurse and I said, I'm a severe hemophiliac. I know how triage works and I'm more than happy to sit in the waiting room and take my time, but could you get me 4,000 units of factor? From that moment, it took me 7 hours to actually get my factor. The blood bank would not release it to a patient. Had I actually had a brain injury, I would have been dead.
While the clinic worked very well, people still provided us with all sorts of stories about situations they were in urgent situations where they were unsafe and where there were medical errors resulting in ongoing conditions that they had to contend with now for a long time. They talked about the Factor First program, but even when they held up their card or their spouse or family members would say, hey, stop, you have to do this first, they were ignored. We heard stories about that over and over again. And where it worked well was where that physician in the clinic called the hemophilia clinic, where the physician, rather in the emergency, called the hemophilia clinic. They gave them advice, but ironically, it was the same advice the patient had given in the first place. There's a desire for partnership among GPs, for partnership with GPs. People with hemophilia that we spoke to would say, I need to be respected, I need to be consulted, and I know a great deal about my illness, more than a lot of healthcare practitioners, so please include me. Focus on what you do well, like diabetes and high cholesterol. Speak to me, but also speak to my clinic. The impact on family was profound. Family was supportive in that they would provide all sorts of support with travel, earning a wage for the family. Spouses often were the primary wage earner. There was also research that they did to advocate for their partners. And there was also this decision about what do we do about children? Do we have children? How does that happen? What are we going to do? People felt guilty about passing along the illness. They felt they wanted to protect their children from the realities of hemophilia, and where there was no family support, people were quite isolated. While we listened to people and listened to the language they were using to spark ideas about programs, we also asked about a bunch of programs listed on the screen there because we wanted people's feedback about that.
Yes, I think that's definitely something as you get older, especially anybody that's a severe hemophiliac. I'm not delusional here or pretending that it's never going to happen to me, because I know down the road, ask me that question in 10 years from now and I'll tell you exactly where I could use some help.
This sense of not now, maybe later, was articulated by everyone, almost everyone, regardless of what age that they were. They felt like, that's nice, but not for me. And in part, it was because of that live now, glass half full. It was, I don't need this. I'm fine on my own. And in fact, my family's taking care of it. And you know, if I needed home support, I would give it. I could call home care. But also, it was interesting because some people were getting that support from other organizations like veterans, like their church, but they didn't see it as support. They didn't say, I'm getting support and I'm getting this for my hemophilia. I'm getting this because I'm part of the veteran community. They had feedback about mentorship programs where they felt, you know, mentoring younger people, that might not be a good idea because there's a generational divide here. They're experiencing hemophilia in a very different way. And I'm kind of crotchety and I'm not quite sure if my attitude is going to impact them. So I don't think I want to share the negativity. So that was an interesting finding as well.
I think part of that is just from childhood and never really knowing what was happening in life. I'm living today. I'll worry about the future. When I get there, there's no real understanding of what it's like to live at that age, 60, 70 with hemophilia. A new kind of uncharted territory of living a lot older with hemophilia.
I think this is one of the most important parts of the study is realizing that the group of men that we spoke to and people of this age group are among the first in this cohort. And there's a lot of unknowns, hence the need for this project, hence the need of discussions. The discussions are happening, but these men aren't sure what the future will hold, and that this was a reality that they didn't know whether they'd actually be standing here. So whether they had concerns about long-term care facilities and Factor maybe being given in long-term care, or they felt vulnerable because their livelihood hinged on products being supplied and covered in the future. It's an area where there were a lot of unknowns. All of this conversation of this research sparked some great ideas, and our next steps have been to brainstorm all sorts of options for new programs. Pfizer's been doing that, the CHS has been doing that, and I have the great pleasure of doing that tomorrow in a workshop with Rick and other colleagues to generate some more ideas for program development. Any questions?
Thank you, Yola. We have time for one question from the floor, and if there isn't one immediately coming, I'll just jump in with one. I know there was all sorts of stuff in this research that surprised me. Was there anything that surprised you?
Yes, in fact, I think that degree of stoicism and the degree of privacy was something that was quite different from other health conditions that I've done research in. And I think it has some huge implications for the delivery of programs for people, because the position and the partnerships with other groups are very important. It's not just about coming to somebody and saying, you need help with your hemophilia. You have to be very sensitive to the way that people feel about the condition and be able to support them in a way that's respectful, and everybody in this room obviously does that now, but I think there's some interesting tidbits about how they can be supported outside of the clinics and outside of the medical environment.
We're going to move on to the next panel. If my panelists could join us up here at the table. We are going to have a panel discussion with patients and healthcare providers on aging with bleeding disorder. So I should begin by letting you know that this may be, this is likely my last opportunity to chair a session. I'll tell you why. I invited David's partner, Patricia, to come up and reflect on what it is to be a partner and a family member and a caregiver to someone who is aging with a bleeding disorder. When I emailed David about this idea, I said, do you think I could ask Patricia? Will she be in Toronto? He said, well, you should ask her, because, you should ask her. But if you're asking me, no bloody way. Anyways, she's here. I'm going to just start this session by asking each of my esteemed aging colleagues a question.
Is that why we were invited?
Yeah. I'm going to ask them each a question. I'm going to introduce them, ask them each a question, and then open it up to you to get to the heart of aging with a bleeding disorder. I guess I'll start with Tim. I've known Tim since I was knee-high to a grasshopper. He was one of the people who helped me become, helped me get to where I am today. So thank you, Tim. He's a hemophilia A patient with severe factor VIII. His pre-adolescent years in Vancouver were marked by multiple transfusions of plasma and long periods of hospitalization. His teen years were impacted by the advent of cryoprecipitate, and his 20s were influenced by both the tremendous benefits and the extreme challenges of factor VIII concentrate. So I guess there's more here, right?
No, that's enough.
That's enough? That's probably enough. You're right. Thank you. My question for you, Tim, is you've always, as long as I've known you, been quick with a smile and a buoyant personality, and you seem typically to be in good spirits. You haven't suffered any less chronic pain than any of us. I'm wondering how chronic pain has affected your life and how you cope with it.
Yeah, the good old chronic pain. Well, as a man of the 60s, we had a lot of it. Actually, it's just not the men of the 60s. It's that I've learned so much here today. And, all hemophiliacs have to deal with it, especially those with inhibitors. So yeah, chronic pain was kind of our life. And you do get used to it a little bit when you're old because you had it so much when you were young. And as I said to some people last night, we used to get fillings on our teeth with no freezing. They were afraid of blowout hemorrhages. So if you wanted a nice grin, you had to grin and bear it. And so it wasn't pleasant. And then nights of rolling around in great pain with this hugely swollen joint, they were pretty customary. Now, to handle it, it really did come to me last night. In the 60s in Vancouver, we were very much influenced. We were all managed by one particular hematologist. That's the way that this was before clinics. And this particular MD, she was very much against pain medication. And so we didn't have much pain medication. And, twice for severe bleeds, I was prescribed Demerol, and that's it. And that wasn't by her. That was by a couple of nice emergency residents who couldn't quite handle this little kid rolling around in pain. So anyway, most of my life I've gone without pain meds. I just have done it. Maybe stoic, I don't know. You get that way. Now, the way it is now, I still don't take pain meds per se, although I hurt a lot. But I do in a sense because I love to move, and I can't move the way I want to move without a little diclofenac, a nice anti-inflammatory that might be not nice on your stomach. And I really do like it. I've been using it, let's say, since 96. And I love it so much. I'm quite careful with its use. I've always, even now, my regimen is, 3 games, a couple of hours each time, tennis, doubles tennis. And I couldn't do it without an anti-inflammatory.
Can I just ask you one sort of follow-up question? In your life, have there been any emotional impacts from that life with that pain that you are willing to share with us?
Yeah, well, I don't know. I can't really say so, Rick. I generally am a happy guy. Yeah. And, I'm quite aware, too. I'm quite aware of my compatriots who haven't been as fortunate as I have been. And so I can go on with a little pain because I'm going on. And so I feel quite fortunate to do what I can do in the body that I do have. And so that a balanced perspective keeps me happy.
Thanks, Tim. I'm going to move on to Pam. Pam is, as you all know, a long time, and these are her words, i.e. aging, volunteer of the global hemophilia community. She's a carrier of hemophilia A, and what I learned, she has lots of problems with bleeding, and she has an undiagnosed bleeding disorder. So I thought it would be a very interesting perspective to have Pam on our panel. So I guess the question is, one of the big issues related to aging with the bleeding disorder is the communication between the HTC staff, our GPs, if we have one at all, and the many specialists that one must engage with when dealing with chronic conditions. When the communication fails, there can be terrible consequences. As someone aging with an undiagnosed bleeding disorder, the stakes would seem to be, to me anyways, to be even higher. How does this impact your life, and how do you mitigate those risks?
So actually, I did volunteer to give up my time to talk about this because I thought it would be more interesting to talk about David. We would take more time because I've spent probably almost as much time with David as you have in recent months. So I'd rather talk about David, but Rick, to make you happy,
I think we could move right on to David. That'd be good with me.
I want to do that. Okay. So anyways, I don't even know. First of all, yes, I do have a family physician. I'm very lucky to have one. And in fact, the physician that I go to is part of the university health team in London. And so we do have residents. We have a program, and it's a very good system because there's always someone there for you. The downside, of course, is that, when you go as the residents turnover, you may see someone different each time. Built-in second opinion, and obviously it should be cutting edge and should be best practice. So that's the good thing. I did have a really good rapport with my family doctor, and I would say that it was built on trust and mutual respect. Unfortunately, he retired. I have a new doctor, and so we're kind of starting over again with that. But to go back a bit, when I say undiagnosed bleeding disorder, I am a carrier. We do know that. But what I've learned is, what do we call it? Am I a symptomatic carrier? Do I have mild hemophilia? I don't really have that answer. So I don't know how our clinic in London would really communicate that with my family doctor, to my surgeon. What do they say? This woman has a 70% factor level. She shouldn't be bleeding. But we know based on history that she has. So it was nothing when I was a child to have 8-hour nosebleeds, prolonged bleeding post any sort of dental surgery, getting braces, that kind of thing. I had 7-day, very, very heavy periods, postpartum bleeding and post-surgical bleeding. Then kind of the final straw for me was I had an injury to my knee and now need a knee replacement. So I bleed, but really I don't fit in the box, so it's difficult. The best thing I can do really is to educate myself, and that's what I try to do. What can I learn? What do I know about when do I bleed? I bleed when I'm challenged. So if something starts, that's it, then I'm on a slippery slope. I bleed when I'm challenged. I've chosen really to educate my family as well, and I've made a decision that my husband isn't my power of attorney for personal care, nor is my daughter. My son is, because he understands the bleeding disorder. He understands the difficulties that I have, and he's well networked. He would know who to call if I was in trouble. So I've given that responsibility to him. I guess to mitigate it and to deal with it, and compared to all these stories here, my bleeding is really nothing, but it could be something. And I guess that's what worries me. If I was in a car accident or needed surgery, it could be a real problem. So I guess I do what I do here all the time anyway. It's networking, it's advocating, it's raising awareness, it's participating in research when I have the opportunity to do so as a carrier, a symptomatic carrier, a mild, whatever you call me. If they ask me to participate, I do that. I've also made a real point of, with my volunteer work, to support, facilitate, and promote inclusion of women at the table, and at the table that matter. And through my work in the international community as well, listening to the stories, encouraging women to speak up, and taking every opportunity that I can to support the physicians and researchers in Canada who are really, really trying to look at this problem. Thank you.
Thanks, Pam. That'll be good to segue. It's one of the largest issues facing the aging with a bleeding disorder community is that when you're living with multiple chronic conditions, you are instantly involved with a myriad, very many specialists that aren't always talking to each other. Pam, it seems like I asked my GP about this. I said, what can we do to make this communication work better? He said, until the system is like radically altered, he said he's not convinced that there is an easy solution. I said, so is it as simple or as difficult as the patient being empowered? And his answer was, I don't see any other answer than you having all the information to make sure that when you're at this specialist, you tell them what's up. I'm not necessarily convinced that's the best or only answer, but Greg is here with us. He has asked me to keep his introduction brief, so I will, because he doesn't need much of an introduction. He's with the Manitoba Bleeding Disorders Program. He's a physiotherapist, and most interesting to me, he's a certified hand therapist. So, Greg, my question to you is there seems to be gaps in communication between HTCs, GPs, specialists, relationships. I wonder if you have any thoughts on how we can ensure that people aging with bleeding disorders and the chronic conditions associated get the right treatments.
Okay. Well, I did ask for a short introduction, and in fact, when you asked me, I just said, just say Greg. And then you said that's like Prince, and someone said like Elvis. Then I realized that both of those people are dead from drug overdoses. So I appreciate that you gave me a little more than just Greg. Listen, I mean, first of all, the aging hemophiliac, right? What is that? Is that a person with joints who has hemophilia and is older, or is that a person with hemophilia who has older joints, right? It's not necessary, and philosophical questions are not good ones to ask at the end of a long day. But I do want to thank all the diehards in the audience who are with us. I think this is really great to see so many people at the end of the day. But I really think that where gaps in communication exist, it's usually because of a lack of understanding. And I think in a group like this, we have two choices. We can look outward and we can look inward. And I think we have to do both. If we focused on looking outward, I would say that it really is our responsibility to make sure that the hemophilia agenda that we all understand so well makes its way now onto general orthopedic meetings, general medicine meetings, psychology conferences. Because as much as these meetings every year, and I think we all really love this meeting every year because it's very empowering and we leave very energized, to a large extent, we all get it. And I think that what we need to make sure happens is that people who are not immersed in the hemophilia world, that they get it as well. What if there was a physio student, a med student, a social work student, and a nursing student here at this meeting every year, deliberately brought from a few jurisdictions? How many more people could that ripple outward to? And would that change the landscape of this gap in understanding, as we roll forward? If we look maybe more inward, I think what we need to consider under the heading of everything old is new again, within our own hemophilia clinics, I think what is ironic is that patients that we have known for years and years are coalescing to form what is a fairly new cohort, and a cohort that we don't have a lot of experience with. And it's hard to look at people you've known for decades and sort of have to look at it from the point of view of the way that they need to be treated is not something you have a great deal of experience with, even if you have a lot of experience with that patient. And that is a bit of a difficulty to wrap your head around. What I think we really need to do is make sure that we leverage all of these, stunning biographies that we've heard of these speakers being introduced, that we leverage our influence wherever we all have it, in medical schools, physio schools, nursing schools, chapter offices, companies, to make sure that we pass along the message of the fact that these hemophilia patients need all of these various disciplines. And the comprehensive care team you need at the age of 5 is not the comprehensive care team you need at the age of 50. And I think we'd all consider it a crisis if a patient with an inhibitor didn't have a hematologist, because that's a really severe complication. But who gets to decide a severe complication? A patient with multiple joint arthropathy at the age of 50-odd who has severe chronic pain, that's a crisis. And a pain specialist or someone educated and equipped to deal with that patient needs that person on their comprehensive care team. And until we view that patient as being in crisis, the same way that we view, I'll say, younger populations as being in crisis, the aging population of hemophilia need to have the same kind of attention that we give the pediatric population. And I don't think that currently we do that well enough.
Thank you, Greg. Patricia has been involved with the Hemophilia Society at the Quebec chapter and national for over 25 years. I'm going to skip the rest of it and just tell you that she's an amazing dancer. My question is, the study that Yola presented seems to reveal something we've all known for a long time, and that there can be a tremendous burden placed on family members of those aging with a bleeding disorder. Could you talk to us about the impacts of being a family member to a person aging with a bleeding disorder and how you deal with them?
First of all, I'm sorry, I couldn't print my stuff out. I have problem with electricity and machines, and every time I touch computers or anything, watches, they all break. So I have to read it from what I prepared here. So I'm going to do 45 years of living with a person with severe hemophilia, hopefully in 4 minutes. And I'm just going to talk basically about the mobility section of it. So I did actually listen to you somewhat, David. So David grew up with monthly hospitalizations and was treated with plasma and whole blood until he was 16 years old. And I met him in 1971, and he'd been using the factor 9 concentrates for 3 years. But he still had to go to the ER to get the treatments. So sometimes that would cut into our dates, but that was okay. I'd go to the ER, and there were quite interesting evenings I spent there with some of these guys. And then he was also on crutches a lot at that point too. So he had definitely impressed me with the twirls, the dancing he could do on his crutches with all of his experience. In 72, we decided to bicycle through Europe on the $5 a day plan, for you, those of you who remember that. And his doctor agreed, and he got to do self-infusion. And so we got a couple of vials and a couple of names to go to Europe, and we went off for a couple of months. He'd have trouble getting on the bike in the morning. I'd put bags on, he'd get on the bike. I couldn't follow him, and he was fine when he got off the bike, and I couldn't walk. So we all have our own times. In the 80s, we bought a market garden and started working that, but field work proved to be difficult for him because of the damage he already had in the joints. And our Farmall tractor he tried to ride gave him kidney bleeds. So I did the field work, and he sold the vegetables at the market. So those were our roles in that kind of work as our partnership went along. It made for him difficult for him to carry a lot of weight with all the damage that he had to his ankles and stuff. And that's when I became the pack horse. And sometimes he couldn't pick up the kids because he just couldn't get up fast enough at night, or he just couldn't. It would cause picking up the kids or anything heavy would cause bleeds. So I became the person who carried everything. And my number one tip to any spouses here, or young spouses of people with bleeding disorders, get a good backpack, because then you have two other arms that you can hold other things, and you always have the crossover bag sometimes, so you can really get strong, The mobility problems sometimes, cut off his things that he could do with his kids other than sailing. But he'd encourage them, and he also managed to be the coach on some of their soccer and baseball teams in the village, and spent his Saturdays doing his work at the ski lodge while the kids spent the day on the ski hills. And I think that one of the positive points, a couple of positive points of David's mobility problems, was that our kids understood, they increased their awareness that people had problems like that. And so it just became normal for them. And I think also the words, it was a nice word, perseverance. They learnt perseverance from their father. Nothing stops them, and nothing stopped. Not much stops our kids either. So I've spoken with a lot of spouses, and there's a couple of things we actually agree upon. Oh my God, I'm only at 1963. These spouses, we agree. These are the most, these guys live in a total state of denial. Deny. I don't have any problems. I'm going to be okay. I can do whatever I want to do, and it's going to be okay. David's philosophy, every type of bleed he has, it's the last one he's ever going to have in his life. So he's already almost got a cure. The second point that we also agree, they're the most, some of the words were nice, determined. Well, we like to say it amongst the spouses, the most pig-headed people we have ever met in our lives. But then it doesn't stop anything, and it doesn't stop them from doing anything. But they try to hide the fact, that they're in pain, that they're having troubles. But we know the signs. We know the limp that happens when everybody's gone by you. We know the irritability that comes up, and it's because the pain is starting. We know that they isolate themselves. So there's no conversation going on. They go into a back room and come out of their den when the pain has diminished a bit. So we just learn to leave them alone. Families have to learn how to deal with changes, last-minute changes to their plans. All of a sudden, they have to cancel it, or he can't come. And so you have to learn how to do that. Prophylaxis helped improve that, because then the bleeds were more controlled. We learned how to help our partners by planning ahead, jumping up in the morning to make breakfast, but they sort of don't know how much we do, but we do these things to save them from having problems. We learn to be independent. If we go traveling, he sits down, has a cup of coffee, I go exploring. Otherwise, I wouldn't see what I was going to see. So we each do our thing, and then we get back together. I fix the things around the house. I get up on the ladders. You need good joints to get up on ladders and change the light bulbs. And I also crack the oysters and the lobsters, just in case. So the limits have definitely had the mobility limits have had an impact on our lives, but it's just our lives, and we get used to it, and that's what we live with. We've had funny times, we've had hard times, like when we both had casts on our left ankle and walking on crutches for a month or so. So that was quite amusing. But I got good too, so I'm never as good. I can't twirl around on them. I'm a good dancer, but I can't dance on the crutches. So, but we take it a day at a time, and every couple's journey is different, and we're partners.
Thank you, Patricia. we are out of time. Craig just gave me his most almost a scowl and a point. I think that was, which is I just wanted to out you for that. I've been doing a fabulous time of keeping this train on the track. So you just keep your watch to yourself, pal. We have time for one question. Hearing none, we can move on. I want to thank the panelists. I want to thank Yola. And yeah.